Assalamu alaikum everyone. Dr. Faiza, are you there?
Assalamu alaikum, Dr. Mubashir. Yes, I'm there.
Okay. Is the scenario visible?
Yes, it's visible.
Okay. Can you please speak the scenario aloud for everyone?
Yes. A 50 years old male, Mr. Zia, presented with right leg weakness for 1 week. He is an ex-smoker. BP is 120/80, pulse 78 per minute, respiratory rate 14, and he is afebrile. Your task is to take structured history, perform a focused examination, and manage the concerns.
Okay. So your time starts now. You can take 5 minutes outside, and after 5 minutes, we will get back to the scenario. Is it okay?
Yes, okay. Okay.
So
We can
your
restart, Dr. Mubashir.
your time starts now.
Okay. Hello and good morning, ma'am.
Good morning.
So I'm Dr. Bilal, one of the doctors from the medical ward. May I know your name, please?
Yes, I am Miss Iqbal.
Okay. And your relation with the patient?
He is my brother.
Okay. Nice meeting you, Miss Iqbal.
Thank you.
So today I'm going to take your brother's medical history as well as do his clinical examination, if this is okay with you.
Yes, doctor.
Okay. And also, I'd be making a few notes. They will remain confidential with me.
Okay.
Okay. So, can you tell me what has brought Mr. Zia to hospital this time?
Actually, doctor, what happened in my brother's case is that he has been suffering from weakness of both of his legs, which was gradual in onset. And basically, it started from the right leg. And after that, in a couple of hours, it involves the left as well. And it has been there since last 1 week.
Okay. So, you're saying that weakness is in the both legs, but it started from the right leg. Is that so?
Yes.
Can you tell me a little detail about how the weakness started?
Actually, doctor, it started quite gradually and it has been progressing. And it is present in whole of his leg, both legs.
Okay. And since last 1 week, this is gradually worsening, or is it the same?
Gradually worsening.
Okay. Uh, Can you tell me, is it the weakness is more in the feet or more in the thighs, or is it the same in both areas?
Same in both areas.
Okay. So, have you felt that there are any factors which aggravate the weakness,
No, doctor.
like any part of the day where the weakness is worse, like at the evening times?
No, doctor. No.
Okay. And any episode when such a weakness has occurred before?
Yes, doctor. It occurred before as well.
Can you tell me about that?
It occurred almost 2 years ago when similar kind of weakness occurred in his legs. And he also suffered from another episode as well. I think
Okay.
one year ago.
What was that episode?
He suffered from loss of vision.
Okay, I'm going to talk to you in detail about these two episodes after a
Hmm.
while, okay?
Okay.
Can you tell me anything which makes this weakness better?
No, doctor. Nothing.
Any medication or any activity?
No, doctor. Nothing.
Does movement make it better or not?
No.
Okay. Is this weakness associated with any trauma to the back
No.
prior to this?
No.
Okay. And is it associated with numbness in the limbs as well, in the legs?
No.
Numbness and tingling?
No.
Okay. Was there any problem with the waterworks or the back passage prior to this weakness?
Doctor, actually, not prior to that weakness. Actually, during the weakness, he suffered from this problem.
What was the problem?
He was unable to pass the waterworks.
Okay, and then did he have to undergo some tube insertion, or was it okay by itself?
Yes, doctor, when we came in this hospital, then the staff inserted the tube.
Okay, okay. So can you tell me, were there any other symptoms associated with this weakness that you must tell me?
Uh, Sorry, doctor, what symptoms?
Okay. Uh, are there arms also involved in this weakness or not?
Yes, doctor, arms are also involved.
Okay. Have how since how long the arms are getting involved?
1 week almost.
Okay. Okay, fine. So, you have told me that similar episode occurred 2 years before and one episode of loss of vision 1 year ago.
Yes.
So, how did those episodes they got all right on their own, or did you undergo some intervention?
Yes, doctor, my brother was hospitalized at that time, and doctors gave him some injections.
Okay,
Mm,
okay. So there were two episodes, one loss of vision and one was the similar weakness. Is that so?
yes, yes, yes.
Is there any history of consumption of large amount of food like ice creams or before these episodes that happened?
No, doctor, no.
Okay, and okay, and any history of paleness of skin complexion that he might have felt,
No, no, no.
or any episode of abnormal movements of any part of the body, like abnormal movements of the arms or head?
Maybe, doctor. I haven't noticed basically.
Okay, okay, and any history of fever or weight loss?
No,
Okay, and any history of cough, long-term cough?
no,
Okay. Is there any family history of such a similar weakness?
no.
Okay. So can you tell me, is there any history of loose stools prior to this? For example, in the last month, there were episode of loose stools.
No, doctor, no.
Okay. Any evening worsening of these symptoms?
No,
Okay. Any recent pains in the house?
no.
Okay. Okay, all right. Is there any history of sudden severe pain in the tummy prior to these symptoms?
No,
Okay, okay. So, can you tell me, is there any history of being unconscious?
no.
Okay. Headache?
No,
Okay. Fits?
no.
All right. So, can you tell me, are there any lumps and bumps in the body?
No.
Okay. How is his appetite?
Appetite is good, doctor.
Okay. And is he able to sleep well?
Uh, yes, you can say it's okay, normal.
Okay. And any rash, spot, or pigmentation on the body?
No,
Okay. Any weather preferences?
no,
Okay. Any history of shortness of breath associated with this weakness?
no.
Okay. And any dizziness on standing up from sitting position?
Actually, doctor, he cannot stand since last 1 week.
Okay. Okay. So he is, what has been his daily activities like? He cannot go to washroom by his own.
No, no, doctor, he cannot walk even. He cannot stand even.
Okay. Okay. So, does he suffer from any long-term condition other than this?
No, doctor, no,
Any diabetes, hypertension, or any other disease?
no,
Is there any allergy to any medication?
no.
Does he take any long-term medication?
Yes, doctor, since last 2 years he has been on medication.
Okay. Which medication? Can you show me his medication list?
Yes, doctor, this is the medication list. This includes tizanidine, amitriptyline, and gabapentin.
Tizanidine, amitriptyline, and gabapentin, right?
Yes.
Okay. So has he suffered from any of the side effects of these medications?
No, doctor, no.
Okay. And was there any recent change of any medication prior to these like weakness?
No.
Okay. He was hospitalized 2 times before, you have told me, right?
Yes.
Any hospital admission other than that?
No.
Okay. And any family history of any inherited condition?
No, doctor.
Okay. And does he smoke?
Yes, doctor. He smoked in the past, but he has left since last 1 year.
Okay. And for how many years he has smoked?
20 years.
Okay. And can you tell me how many cigarettes per day on average?
10 cigarettes per day.
10 cigarettes per day. Okay. And does he take alcohol?
No, doctor.
Okay. And what was his job? Does he do any job?
Yes, doctor. He was driver, but he's left his job since last 2 years because of his illness.
Okay. And before, okay. And has he changed any profession, or he was driver from the start?
Yeah, from the start.
Okay. I'm going to ask some other personal questions, but they are necessary for the diagnosis. Does he take any recreational drugs?
No.
Okay. And he is now unable to drive, you are telling me, right?
Yeah.
Okay. And any recent travel to before the onset of these symptoms?
No, doctor. No.
Okay. And has he been taking his vaccinations regularly or not?
I'm not sure, doctor.
Okay. And what was the effect of his disease on his daily life? You are saying that he is now unable to carry out his job. And what about the daily activities since last 2 years?
Doctor, it has affected him a lot. Basically, he has been depressed, and since he left his job, it is quite affecting him financially as well and emotionally as well.
Okay. Okay. I will definitely talk to social services and occupational therapists regarding to this problem, and they will help you
O-
hopefully.
Okay, thank
So
you, doctor.
now I'm going to examine the patient.
Okay.
I will start from the lower limbs. I will start
Mm.
from the hands basically. Uh, and Rather, I would start from the lower limbs first. Okay, I will look for the any obvious wasting or fasciculations.
No
Then I
wasting,
would
no wasting, no
okay,
fasciculation.
okay. Then I would check tone of the bilateral lower limbs.
It is
How
hypertone,
is the tone?
hypertone,
Okay, okay. And what about power?
zero power in both proximal and distal muscles.
Okay, and reflexes.
It is hyperreflexia.
Okay, and coordination. He is not able to perform coordination, right?
Yes, yes,
And
doctor.
what about the planters?
And they are upgoing. Extensor plantar
Okay,
response.
okay. And what about the sensory system, the pinprick sensation?
Pinprick and soft tuck both are intact. Sensations are normal.
Okay, and dorsal column joint position is also intact.
No, joint position sense is impaired.
Okay, joint position is impaired. Okay, now moving on to the upper limbs, I would check the power of the upper limbs.
It is 2 by 5.
2 by 5. Okay, and reflexes in the upper limbs.
Upper limb hyper increased.
Okay, and finger no, since I would also check sensation like pinprick is intact.
Yes.
And okay, and what about vibration and joint position?
It is impaired, doctor.
Okay, and I would check finger nose test.
Yes, doctor, it is positive.
Is he able to perform
Yes,
finger nose
doctor.
test? Okay,
Yes,
and it is positive.
it is positive.
Okay, and I would also like to check dysdiadochokinesia.
It is also positive. Doctor, 2
Okay,
minutes are left.
okay. I would check the eyes for any nystagmus. How are the eyes?
Yes, doctor, nystagmus is present.
Okay, so do you have any concerns, Miss Iqbal, relating to your brother's diagnosis and management plan?
Yes, doctor, I have many concerns. Basically, can you please tell me what's going on with my brother?
Yes, I can tell you what's going on. Actually, your brother, after doing the history and examination of your brother, I have come to realize that he is suffering from a disease which is called as multiple sclerosis. We would be more sure about after the investigations, but I can tell that this is a disease in which there is some problem with the cells of the brain and spinal cord, and that problem leads to these various symptoms of like sometimes affects the eyes and so gets loss of vision, sometimes it affects the muscle, so there is muscle weakness, and there are treatments available for it, and we will manage them according to those treatment plans. And sometimes the disease gets in remission and he can remain all right for some time. It could be in months or years, and then if again another episode occurs, we have to treat that as well. So do you have any other concern?
Doctor, will you admit my brother today?
Yes, we will admit him today because this is a new weakness and it is also progressive, and the arms are also getting involved. So we have to admit him for some injections, and we will give him some injectable medications. And after a few days, when he becomes all right, then we can plan and discharge him.
Okay. And doctor, will you can you tell me, is it curable?
I'm sorry to tell you, Ms. Iqbal, that this disease is not completely curable, but it can be managed. We have a very expert team of doctors, including the brain doctors as well as physiotherapists, and we will be jointly treating and managing your brother, and all of the complications and whatever he is
Okay, doctor,
facing, those
time is
problems
over.
can be managed. Okay, thank you.
One more
Thank you,
concern
Ms.
was
Iqbal.
left. One more concern was left. Okay. So, uh, doctor, can you please tell me your positive findings in the history?
Yes, I can. This patient, Mr. Zia, 50 years old male, presented with bilateral lower leg weakness, which was gradual in onset, 1 week in duration, and progressively increasing. It was there were no particular aggravating or relieving factors. However, the weakness was associated with episode of urinary retention, as well as he also gave history of two similar episodes where 2 years ago a episode of weakness of bilateral lower limbs was there, and for which he got admitted and he got treatment, and which improved later on. And 1 year ago he had an episode of loss of vision, for which he was also admitted and he was on some medications. Other than that, his medication history included tizanidine, amitriptyline, and gabapentin, and he is a known smoker as well. He has 10 pack year history of smoking. His life has been badly affected because of this disease, and he has stopped his occupation as well since last 2 years. He is financially and psychologically affected because of this disease. And
Positive
that
findings in your examination.
okay. On examination of this gentleman, he was cooperative throughout the examination. He was conscious, and on examination of the lower limbs, there was increased tone in bilateral lower limbs. Power was 0/5 in all muscle groups, and reflexes were brisk, and the planters were upgoing. Coordination could not be checked because of low power. And on sensory examinations, pinprick and soft touch were intact. However, joint position and vibration senses were lost. On examination of the upper limbs, also power was 2/5. Reflexes were brisk, and pinprick was intact while joint position was impaired. Finger nose test was positive, and so was dysdiadochokinesia. And on examination of the eyes, there was nystagmus. Based on these findings, I have a diagnosis which might include a demyelinating pathology, because three different areas of the brain and spinal cord have been affected, including the corticospinal tract, as well as cerebellum and dorsal column as well. And these are also disseminated in time and space. So, based on these findings, the most likely diagnosis is multiple sclerosis.
Okay, doctor, do you want to add some examination here which you missed?
Yes, I would like to do a fundoscopy of this patient
Mm,
if I had the time. And I would also, other than that, I would like to,
mm. So, what is your differential
that's
diagnosis?
all. My differentials for this case would be, it could be subacute combined degeneration, but since cerebellar signs were positive, so I kept it down the list. Other than that, it could be if the patient was younger and there was family history, then I would have considered Frederick's ataxia, but this is not the case here.
Okay, how will you
Other
investigate?
than I will investigate this patient with, first of all, I would start with CBC and peripheral blood film. And then I would go for, I would do the chest X-ray as well as the scans. Basically, I would want the MRI scans of the brain and spinal cord. Other than that, I would like to go for a lumbar puncture to see the CSF or any if there is any inflammatory cause to it, to rule out the inflammatory cause. And other than that, I can also go for nerve conduction studies and EMG. And other than that, I think that's all.
And
I
how
can
will
also
I,
do X-ray of the spines as well.
how
Since
will,
this is the acute episode, yes, since this is the acute episode, I would like to manage him with high dose. Actually, I would go for non-pharmacological and pharmacological management of this patient. In non-pharmacological management, I would include a multidisciplinary team. I would take a multidisciplinary team approach with a neurologist as well as a neuropsychiatrist, a neuropsychologist, as well as a physiotherapist and occupational therapist. And also, I would take a dietitian with me. And I would do education and counseling of the patient as well as his attendants. I would tell them about the disease. I would try to improve his functional status by physiotherapy. And I would try to improve his, because he was financially suffering, so I would also get any social help possible for him.
okay, doctor, time is over.
Then I would, okay,
So, Dr. Faiza,
pharmacological.
hmm,
I'm
it was
sorry.
a good attempt, but I would include some points over here. After 9 minutes, this Zoom session will stop and I will share another link. So, what happened in this scenario is basically overall it is a good attempt, but I would suggest that try to complete your history in 6 to 8 minutes. 11 minutes is too much. Here you go for 11 minutes. Neurological examination itself will take 6 to 7 minutes if you want to come towards the hands, in the arms as well as in the eyes. So, when I was telling you the examination, I told you each and everything in just 2 minutes. So, this will not happen in the exam now. You have to pick the findings yourself. You have to do each and every step. So, try to manage your history in at least 8 minutes. Okay, because
Okay.
till 8 minutes you have come only towards clinical communication skill. Till 8 minutes, only the thing which was checked was clinical communication skill. After that, you when you stand up, then there came physical examination
Physical
and
side.
identifying the physical signs now. So try to manage your time accordingly. No doubt this is a very lengthy case, but this is the exam scenario. This was my case, my first case in the PACES exam recently in the January, right? So what happened is that another important thing which I noticed during your history taking is that don't repeat the things. For example, here the surrogate will tell you maximum things. Just keep on writing those things. No need to confirm them back again. No, when I was telling you gradual in onset, progressive weakness, both legs, no, nothing like that. Matlab, so don't repeat them. This will just save your time. Okay, and uh, another thing is that when you localize that where exactly the weakness was, then your first question should be whether the legs feel heavy or floppy, right? In when
Okay.
you feel
Yes.
like this, sometimes the surrogate will not tell. For example, if the examiner have not told them, for example, it was in my case, they haven't told him that whether it is heavy or floppy. He got puzzled. He said, I don't know. Okay, so if the examiner has told her that they will feel heavy, this will save your time. Instead of asking the questions of flaccid paralysis, you will not, you will just save your time now. So This question you should ask in the start. Okay. And whenever there is weakness in the legs, ask for weakness in any other part of the body, for example arms, face, or anywhere else. Okay. And after that, uh, don't become haphazard now, because what happened is that your each and every skill is being judged over there now. They can write in your feedback that the history was a bit haphazard. They will not deduct much marks, because out of 4 marks they can't give you zero, obviously, but they can give you 1 mark. And let me tell you one thing, that in basis each and every mark has its importance. Okay. So when you were asking about Odifara, okay, very, very well. After Odifara, must ask about all the symptoms of CNS. Okay. For example, when you come with paraplegia, here it is paraplegia, must ask about any difficulty in walking, difficulty in swallowing, difficulty in vision. Okay. So here she will tell that no, this time there is no difficulty in vision, but it occurred before as well. And this is very good that you start. You asked in the start that any weakness, similar weakness before as well. Okay. So whenever this is a case of weakness, whether it is paraplegia or it is a stroke, you should ask na, okay, any weakness history before as well. Okay. And then all other questions of CNS, for example, yeah, yeah, it's good you ask about the control of waterworks, control of bowel works, but also ask about double vision as well na? And also ask about for example uh, for example, in case this case, for example, you are not clear that whether it is multiple sclerosis or not, but when the surrogate told you that yes doctor, it occurred before as well, it occurred, there was a loss of vision before as well, so you should think about the multiple sclerosis. Now you are getting your mind that it may be a case of multiple sclerosis, or either it will be a case of periodic paralysis. Only these two conditions are coming in my mind at this time, that they have a recurrence. So here you can ask about history of weakness with hot water, for example in summer, or hot water bath. It will leave a very good impression on the examiner. They will they will not deduct your mark in any other place. For example, if you may lose something, they will have the impression that this candidate is a very well, he has much knowledge now. So also ask about any history of current like sensations in the arm. I mean, I'm talking about Utah phenomena or Lerman phenomena.
Hermit sign. Yes, yes.
Yeah, yeah. So this was an additional thing. Rest you ask about all CNS questions, but after this, instead of jumping to family history, come in the sequence now. General questions you ask very well, they were all no. After that, come to past history, allergy, medication, okay, hospitalization, everything was up to the mark. But in occupation history, where the patient surrogate told you that my brother was a driver and he has left his job since last 2 years now. So here you should be some show some empathy now. Okay, I'm so sorry for this. We will refer you to the matlab, you should add this sentence that I'm so sorry, just like this. Other you mentioned that we will give you some support or something like that, no? And before starting social history, before asking about smoking, before asking about alcohol, give warning sign here, not when you were asking about illicit drugs, huh? Because alcohol is also not so ethical to ask. Okay. So this
Okay.
was all about this. And for example, if it was a female patient, you should also ask about 3 P's, that is period, pill, and pregnancy. But mostly what happens is that in Pakistan, especially in Rawalpindi center, since the pieces has start in this center, I haven't heard that ever they have given some female patient. They have always given a male patient who is quite cooperative and something like that. But you should keep this in your mind that in case if it is a female patient, you should ask about a period, pill, and pregnancy. Okay. And another thing which I want to add is that when you were telling about your history presentation, try to complete it in early, because the basis examiners will not mind that you haven't touched the topic of investigation or management. They will only deduct your mark in clinical judgment. This is what happens opposite to FCPS exam. Okay, so you must reach your those I mean steps on your own. So this will only happen when you will just tell your positive points in the history. No need for good narration, just which happens in FCPS exam. No? And sorry, another hint or another tip I want to give you in your examination, when you were telling your positive points in the examination. For example, when you will tell they guess this patient has increased tone, this patient has zero power in both problems. Instead, you can just say that in my lower limb examination, patient has upper motor neuron type of paralysis as evidenced by hypertonia, 0 by 5 power, hyperreflexia, and extensor plantar response. Okay, it will save your time. And another thing is that, Dr. Faiza, when I told you that this patient has hyperreflexia, so you should check the clonus. Okay.
Yes, okay.
Okay, and then you will tell that the sensations are normal in terms of pinprick and soft touch and vibration and joint position senses impaired in the lower limb. And I couldn't check the gait and heel chin test because of zero power. Coming towards the upper limb examination, you will tell just that the pronator drift is positive, because in real exam you will not have to, you can't assess na each and everything because you have only 14 minutes. In actual, it is 14 minutes. You have 6 minutes for history. I mean, this is the thing which you should follow. Take 6 minutes history, 6 minutes examination. This will cover 12 minutes, and then 2 minutes for concern. Because sometimes they will give you 1 minute for recollection of your thoughts, and then you will come to Viva, or either they will just call you for Viva immediately. Okay, and when you are checking for nystagmus in the eye, so you should also check for internuclear ophthalmoplegia. Okay, so
Okay.
this was all about this. For example, if in the exam patient does not have 0 by 5 power, for example patient has 3 by 5 power or 4 by 5 power, and you need to check the gait of the patient, what gait can come in a patient of multiple sclerosis. I think the recording will,
Spastic gait.
yeah, it will spastic gait. It will be, it can be wide
Is
based
it?
8XA.
Yes, Dr. Mubashir, please continue.
Okay. So I was telling about the gait. Okay, that's okay. And for example, if you speak to the patient, which mostly in Pakistani centers it is not possible, but when you are taking the consent from the patient, you can assess at that time, no? Okay, whether his speech is slurred or not. And investigations you told very well. It's okay. One I want to add, I think you have missed this VL evoke potential now. That,
Yes, yes.
and during investigations you will tell all about what you will see in the investigation. For example, you will tell about VL evoke potential, that there will be delayed velocity but normal amplitude. And during your CSF analysis in lumbar puncture, you will look for oligoclonal bands. And likewise in MRI brain and spinal cord, you will look for the white matter ligands. Okay, and also you can tell about McDonald diagnostic criteria. And in management plan, you tell very well about the general management. But few things I want to add is that, for example, a SALT team or SALT therapy, speech and language therapy. This is important in
Yes.
neurology cases. Now. So add this one as well, and specialist nurses as well, and multiple sclerosis societies, and also walking aid and VL aid as well. No? Rest is all okay. Specific treatment and disease modifying therapy we all know, and supportive therapy. For example, the patient was already taking, for example, that baclofen and tizanidine for spasticity, for depression, tricyclic antidepressant, and self intermittent catheterization for his urinary retention, etc. Okay, so overall it was a good attempt. Just try to manage your time, and that's all. No? So
Dr. Mubashir, I had to ask that HIV can be a cause of neuropathy. So can we ask, do we have to ask about sexual history in this patient or not?
I would suggest no. Reason being is that uh, HIV will lead to sensory neuropathy as well. But here patient has, it doesn't lead to zero power, na? And patient will have, doesn't have the history of a similar kind of weakness before as well, and that optic neuritis episode. Because when the patient was
Yes.
telling you about VN loss, na, so you should just confirm that whether the VN loss was painless or painful. He will tell you painful, so this will confirm that this, yes, this was an episode of optic neuritis. This will favor your diagnosis of demyelinating disease, multiple sclerosis more than HIV. Na? And another
Okay.
important thing is that, for example, if in any case you consider that this is not, for example, sexual history is not that important, your marks will not be deducted. Na? So this was all about today's long clinical consultation. Any questions from anyone? Or you can write in the chat box.